recording? Great, thank you. Well, welcome everyone to the EBA tag 2.0 extended version here. We've added more people and more time, and thanks for giving up your Monday afternoon. I'm Sarah Nipper, the OHA staff person supporting this work. And Glendora, do you want to kick us off with some introductions here?
Sure, why not? Hello, everyone. As Sarah has said, my name is Glendora Clay-Brooks, and we are starting our agenda with introductories. And as such, I am going to start with Dr. Ed Jenkins. Please introduce yourself, sir.
Yeah, hi. Thank you very much. My name's Ed Jenkins. I use he, him, his, and I'm a pediatrician down in the Corvallis area. I serve the task force as the vice chair. Thank you.
Thank you, Dr. Jenkins. Dr. Metz, please.
I'm Sam Metz, a recently retired, rapidly aging anesthesiologist, and I'm officially a member of the Finance and Revenue tag.
Thank you. Dr. Santa, please.
John Santa, retired primary care doctor. I used to work for Open Notes. And Laurel, if you could remove that, because I no longer do, I would appreciate it. I continue to have problems with that showing up on some Zooms and not on others. Thank you, Laurel. That's me.
Thank you. And I'm going to say Dr. Chuck. I'm afraid of mispronouncing your last name. And you're on mute, Chuck.
Okay, so I'm not a doctor, but like Dr. Science, doctor is my first name. I'm Chuck Sheketoff, and also fairly recently retired, and most recently to that, ran the Oregon Center for Public Policy, and I am the chair of the Finance and Revenue tag.
Thank you, Chuck. Dr. Junkier.
Thanks, Glendora. Hi, everyone. Xenia Junkiri, she and her pronouns. I'm currently the director at the Oregon Health Equity Alliance, one of 6 regional health equity coalitions across the state, and I'm a naturopathic physician by training.
Thank you. Dr. Ramirez.
I'm also not a doctor, but thank you. I'm the director of the Association of Oregon Community Mental Health Programs. And I usually chime in about behavioral health in this particular task force. So that's why I'm here, just to look out for behavioral health interests.
Collins.
Good morning, everyone. Mike Collins, he, him, his. I'm the director of management for the Confederated Tribes of Warm Springs. It's nice to see you all.
Thank you. Did I omit anyone?
Thank you. Got everybody, Glendora.
Okay, so I'm going to turn it over to, well, I guess I'll just briefly state what our agenda encompasses. Well, we're going to have our vice chair, Dr. Jenkins, talk about, recap the task force goals. And we're going to talk about the evidence-based benefits in Oregon. And the key values and considerations for our eligibility benefits affordability tag. Then we're going to take a break. Then we're going to go into the proposals, and then we're going to have a discussion. So then we will talk about next steps and have space for public testimony. At this time, I'm going to turn it back into the hands of either Sarah or Dr. Jenkins.
Yeah, thanks, Glendora. Before I turn it over to Dr. Jenkins, I did want to make sure that I introduced Janine Smith, who is part of Health Management Associates, HMA. HMA is our contractor supporting this work. They have been doing a lot of work behind the scenes, but we thought it would be really helpful to bring Janine in today because she has such a deep background and history in doing benefits design. And so she's going to be doing a lot of the heavy lifting on the materials that are going to be presented today, and we'll be sort of jointly facilitating discussion. But Janine, do you want to say anything before we get started?
No, thanks. I've been at HMA for the last 5 years, but many of you know me from my past days at doing state service for 15 years as the Office of Health Policy and designing benefits. I was on the PEB board for 10 years and helped to develop the patient-centered primary care home model and work on CCO development. I have continued to practice from old days of private practice, working with tribal organizations, both in Oregon and Alaska, and have been continuing to consult with a variety of practices, as I also see patients part-time at OHSU Richmond as a family physician for the last 20 years, surprisingly. So.
Thanks, Janine. Okay, so I'm going to turn it over to Dr. Jenkins, who's going to make some remarks and help frame up some of the discussion that we're going to have today.
Yeah, perfect. Thank you very much, Sarah. Yeah, so at the end of today, we hope to find some success. And sometimes it helps to just frame success so that we're all thinking about it and visualizing it the same way. If we want to be successful. And so it might be a good idea for us to revisit what might be accomplished today in really just 3 loose, broad categories. We've put a lot of work into this. It's not just this particular tag, all the tags and all the task force members have put a lot of work into the plan to get us to this point. As we move forward today, I would like to remind our group, our tag, that everybody's voice is important and necessary to be heard and is respected. That means if you feel like you need to say something, please say it. If you feel like the discussion is going in a direction that you are uncomfortable with, please say. We also have a charge from the task force that we are needing to be respectful of the task force recommendations, which I will try to summarize in the next couple of slides, and the direction that was given to us by the task force. And then finally, when all is said and done, we need to develop clear recommendations to bring back to that task force. So we would be considered successful if we hit these 3 measures, certainly in my opinion. Next slide, please. So let's take a look at the timeline. Just as a recap, February 25th, the task force reviewed a proposal from the EBA that was based on the PEB plan and didn't include limits and didn't include cost sharing. This is sort of an initial draft that was put out by the EBA tag, during which there was a robust discussion about establishing places where limits were appropriate, maybe to ensure sustainability, and to somehow think about a role for the social determinants of health services and how that might fit in. After that meeting, staff went back and edited the proposal based on feedback from us as a task force group, and then brought it back to the EBA, the smaller EBA group. At our March 8th meeting of the EBA, the tag reviewed and edited the benefits proposal part of that. And during that discussion, there were additional limitations that were put in place, as you can see, and some minor adjustments and recommendations brought out for cost sharing regarding ER visits and potentially some prescription drug savings. And then finally, recommendation to pull out the social determinants of health and the prescription drug conversation for another study, not to lessen their importance, but just to clarify what we are bringing forward for the March meeting. At that 25th task force meeting, the EBA benefits proposal was presented. And at that time, we recall, the group decided not to vote on it because many people expressed openly concerns over elements of the proposal, that is, people within the task force. Though several themes emerged, and Chair Goldberg invited the EBA and an expanded membership to revisit those recommendations based on the task force feedback and try to come back with clear recommendations again at our upcoming meeting. Next slide, please. And so some process reminders today. The tag is going to look at the specific feedback of the task force, which you've seen in your slide set, and engage in thoughtful discussion and reflection. We have staff and we have HMA representation to help us incorporate these edits into a revised benefits proposal. So if there are areas where consensus can't be reached, minority views will be reflected in the proposal. And remember that while today we expect to find success in a clear recommendation, there will be time at the task force meeting to vote on the proposal that you are talking about today, to discuss it, to refine it even further. That will be presented at our upcoming meeting on the 29th. And then the task force will decide whether or not to accept it. That's accept it with reservations, or not accept it at all. And then the reservations or reasons for not accepting it will be, captured and documented in a report. And if necessary, those items will continue to be worked on an extension if that's what happens. Next slide, please. So let me talk briefly about what we heard at the last meeting. We heard, for example, Glendora say, we need to think about how benefits will impact other components of the plan. We heard Chuck say, we don't need a Lamborghini, a Cadillac will do fine. I said, we don't need to match the best plan in the nation. John reminded us that the hearing aid benefit alone would cost us in excess of $2 billion. Sam asked us to consider incorporating medical necessity. Cheryl reminded us to revisit the behavioral health component of it. There were concerns about medical profiteering. The need to consider limits was brought up several times. And then we were asked to reconsider graduated income premiums for higher income folks, using Medicare as a model in order to decrease burden on low income families, as well as to consider a single drug list for the state, and to consider an evidence-based system for determining benefits like the HERC. Next slide. So to summarize the feedback, the expectation as has been put forth is that benefits is grounded in an evidence-based process, incorporates medical need, considers mechanisms for utilization management controls, revisits premiums on high-income families in order to decrease the burden on low-income families, considers a single prescription drug formulary for the state, and then, of course, keeps in mind behavioral health. So in reflection on the original benefits proposal for today, I just wanted to open up the floor for 10 or so minutes to just talk about and to reflect on what we discussed as a task force last month. Maybe that original proposal, we've had a few weeks to think about it. Are there thoughts now that we've had 2 weeks to plan to come together again? Reactions to the task force feedback now, and then of course we've seen the slide deck for today. What is going to happen? So I'd like to open it up now for 10 minutes to see if we can grab comments that will help us move forward clearly. And I want to also put on the table, what if we move forward with the proposal that we just put before the task force at the last meeting? What would it look like are the ups and downs for that? Now that we've had a couple weeks to think about it. So with that, I'm going to open up the floor, see if I can manage what I'm looking at here.
Ed, I haven't used the participant button, but I have a few comments to provoke others.
Thanks, Sam.
I withdraw the comment about medical necessity. I think that's inappropriate, and I believe we should not define individual benefits, but essentially put together a benefit package from other pre-existing benefit packages like PEB. I still wonder about the concept of cost sharing and why we're talking about that at all. Increase revenue because the cost of collecting it exceed the cost that we'll get. We do not want patients. We do not want patients to tell their physicians, if you prescribe this drug, I can see two exceptions. One is prescribe a drug that is sharing. Second, taking John Santa's comment to heart about the potentially infinite cost of medical devices. When it comes to medical devices, we can say that the plan will cover the first X amount of money for the device, which should take in at least one option, and then have a cost sharing provision for patients who say, I've got extra money, I would like the Lamborghini. I would finally just say, we should not be talking about premiums at all, ever. The cost, the administrative cost of collecting premiums, the administrative cost of detecting who is going to pay how much, and revise that year after year for every applicant is a place that we are trying to run, not walk away from. If we want to make the burden easier on poor families, that's the purpose of the Finance and Revenue Committee, which can design as progressive a tax as the tax force determines. I'd see no role for premiums.
Thank you, Sam. I'm just going to really summarize. You made some very clear points. The first is to withdraw your comment about medical necessity. Then secondly, the cost sharing statements, maybe to include exceptions such as drugs outside of formulary or devices where people may elect to pay more. And then lastly, to run from the talk of premiums because of the administrative burden and cost of chasing this stuff down. Is that more or less what you are putting on the table?
Yes, I should have let you say it and it would have gone much quicker. Thank you.
No, I love it when people talk and it's not me. Yeah, go ahead, John.
Yeah, basically, I think I have concerns around three themes. The first is transparency. And part of transparency is being honest about what you can do, but also what you can't do. Every benefit design I've been involved in has a exclusion list, for example. You know, we haven't gotten to that. Every benefit design I've been involved in does have some key themes around, do you pay for research? Do you pay for things that aren't medically necessary, as difficult as that term is? So I think from a transparency point of view, especially when you're doing something in the public domain, you have to be transparent about what you can do and what you likely can't do. The second theme for me is I know that there's three areas consumers really care about: quality, safety, and their experience. And actually, in all three cases, to do a good job of those, it has to be clear, especially to providers, that they have some restrictions around their behavior. You know, quality improvement is actually about standardization. And while standardization has its risks, you cannot have quality until you have some degree of standardization in a system. And I can give you many examples. And then the third is stewardship. We are talking about a company, an organization that will be stewarding $40 to $50 billion a year. That company, that organization, and 770 makes it clear that single payer is going to be held accountable for good stewardship. And I think that's going to be very difficult to convince anybody we're committed to good stewardship if we're not transparent about the limits on what we're going to be able to do. Those would be my three concerns.
Thanks, John. And again, what I heard was number one, transparency, especially what can't be done. Number two, quality, safety, and the patient experience, and the standardization within the system. And then finally, stewardship of the 770 company and transparency therein. All right. Others, we have a minute or two. Chuck, there you go.
Yeah. So I think pretty much everything John just said. I guess I would put in that, as far as benefits go, I think we need to have a process that's transparent and easy to understand and all that, that you don't need a lawyer for if you are being denied something, like if we have a list like the Oregon Health Plan. If your service if a doctor believes it's medically necessary, but it's below the line, there's a process now. It's too complicated to get it covered, but I think there needs to be some way to deal with that exceptions, because I think the idea that we can think ahead of all those is ridiculous. And as far as eligibility and benefits, I mean, I do think we should consider premiums for higher income people. It's an indirect way to get at assets, wealthy people that you can't get through the sort of more targeted than with the tax system in some ways. But having the transparency and understandable, that people know no one's hiding the ball on stuff. So I'll leave it at that.
Thanks, Chuck. Again, what I heard was quite statements about process and transparency, especially ease in understanding why you're being denied if a medical provider said that this is necessary. And then you're putting your voice behind the premium or finding a way to either tax or to increase the burden on the higher income people.
Yeah.
And thank you all. Any others? Was there something else? I'm going to go to Xenia real fast. Go ahead.
Yeah, I appreciate hearing from folks, and I think maybe everyone we've heard from is a EBA Plus member, right? So I appreciate your reflections on the proposal from a place of hearing and reflecting on how you all heard that proposal offered. And I think for me the challenge that we have here is that we're trying to make some decisions already, I believe, about what is in, what is out, how much is this actually feasible, politically feasible? Is this this being the plan, something that we think we can get folks on board with. Could we even generate that amount of money through existing revenue mechanisms, whether they're new for us in this state or just increased? And at the end of the day, I think as a EBA tag, one of the challenges we had during the entire process was that I think we all know that there are limitations on, how much money we can generate and spend on this healthcare system. And we wanted to be really clear that we were grounded in everybody in, nobody out, access to all necessary services. We went through services. We talked about whether or not we thought those were, we wanted to include them, et cetera. But during the entire time, I think that there was this feeling in most people's minds that led us to have conversations even early on about, oh, we just can't fund this. This is just going to cost us too much money. So let's start pulling at this point, some things that are going to cost too much money. And for me, the reason that I couldn't vote on this last week, I actually could have voted on it last week, but I would have voted for us to send our best effort to a robust community engagement plan so that we could get input from others. Because I don't actually think that this group, including the entire task force's role, is to enumerate all of the benefits that are going to be offered in this design and then send it to the legislature and say, this is what we have decided, right? I think we are one part of a hopefully larger process that will help get folks on board, because we know this will either go to the voters or people will end up, carrying the burden of these additional revenue generating streams. And so I wonder if there's some conversation about like where we are either in alignment with our values and or where our non-negotiables are around, removing benefits based on some considerations we have about cost that may or may not be the role of this tag, and that we may have some fear that if we send it to the finance and revenue tag, that they'll say, actually, we've had 20 billion in our mind. What you proposed is 40. So we're going to start cutting things because we think it's only feasible that we're going to raise and generate this additional $20 billion in funding. So in some ways, I think this tag was set up from the beginning to make it hard to be successful, because the ask is influenced by so many other factors. And at the end of the day, I don't think the task force's role was to make that specific of a recommendation just from the task force to the legislature outside of other efforts to ensure that, we are not missing gaps and or that we are accountable for the fact that we're already talking about removing services, from the coverage folks will receive. And that for me feels really important, accountability wise.
So thank you, Xenia. I'm going to, first of all, that's a very excellent point. What I heard you say was, I feel like we're editing ourselves. We're maybe even editing out our values before, after having a conversation, many conversations in a complex world, and we're not putting forth a benefits plan that reflect our values, knowing that downstream there are going to be legislators and community members who are going to be doing that anyways. I want to be respectful of the momentum and the agenda. So I'm going to cut us off right here. Please hold on to other thoughts you may have, because we're going to have lots of opportunities. Let me turn this back over to Sarah, and because I think that's what's next. I lost track of.
Thanks, Dr. Jenkins. So we're actually going to pivot now, and we're going to just have Janine give us kind of an overview, a history of how we've used evidence in Oregon, which I think will help frame up some of the discussions we're going to have later. And then after that, then it will be turned over to Dr. Junkier and Glendora to kind of bring us back to some of those values and considerations components that I think Dr. Junkier was just reflecting on. So Janine,
Yep.
will you? Oops.
So in response to some of the discussions at the task force, we thought it might be useful to go over this briefly. I won't read all the words because you have all had this for a few days, but just wanted to remind you about the longstanding history in Oregon of using evidence to help develop policy when talking about benefits and coverage. We're notorious across the country for our initial Oregon Health Plan having what was called a prioritized list of health services. It was originally developed by the Health Services Commission, which is now called the Health Evidence Review Commission, and started back in the, actually started way back in the late 80s and was officially approved by the, for Medicaid in 1994. We also have subsequently over the years also developed some work in the prescription drug arena with a practitioner managed prescription drug plan. And so we'll go over these just a little bit more on future slides here. Next slide. So the notorious prioritized list, which is not used by any other states in the country, although a couple of countries, I think it's Taiwan and a couple have actually have used it, is a ranking of health services in order of importance to the population being served. It's very specific. It has the condition and the treatment, all the millions of codes around whether it's diabetes or asthma treatment and surgeries for cancer, et cetera. And the prioritization is based on the impact on health, its effectiveness based on a pretty robust look at the literature, and then some thoughts about the cost. But that's a lot more of when there's a tiebreaker on the other two aspects. It includes and together both medical, behavioral, and oral health conditions, so it's not unique to just one part of the body. It is used to determine what we are able to cover with taxpayer dollars under the Oregon Health Plan or Medicaid. It determines the benefits specifically for those who are an open card fee for service. And it's a floor of coverage for the CCOs. The CCOs can cover things beyond what the list if they decide, working with their providers and with their enrolled members. But it is a floor of coverage. And then PEB and the commercial plans have also looked to it. I know in my experience on the PEB board, we looked at it sometimes when we had to think about benefit coverage decisions. We would look to that. And I've had conversations with many of the commercial plans and over the years on how much they will look to see what's being covered on the list and crosswalk it with what they're covering. It's determined by an independent commission, now called the Health Evidence Review Commission. The legislature can't readjust the list, but they can decide where the line is drawn into what's covered. And it is these decisions of where things is through a public process with public input. Next slide. So the Health Evidence Review Commission, it's governor appointed, Senate confirmed, they're volunteers. I think we only pay for travel just to make sure they can get to the meetings in the old pre-COVID days. Now they're all virtual. It's a wide representation of both clinical folks as well as consumers and insurance industry representatives. And they produce the list, and complementary to the list, they will go through and set some guidelines. For instance, for a vaginal hysterectomy for bleeding, they'll say you make sure you've done this, this, and this based on the evidence first before authorization to go proceed with the surgery. But the list has 700 some lines, of which the line is drawn, and I never can remember exactly because it changes a little bit, but because of the way they number it. But around at least 2/3 of the list is currently covered. Next slide. They build, much like what is mentioned in 770, the resources they use to decide the evidence is the United States Preventative Task Force, and they look at Bright Futures and many of the other ones that are listed in 770. They work with OHSU for a very exhaustive look at the literature of evidence and very rigorous articles that they will consider based on that it's been peer reviewed and substantial impact on health. And it's not just about safety and efficacy. It is really what is the value of that treatment compared to other treatments or procedures. They don't do drug reviews themselves. They defer to a second organization that's also voluntary and open to public meetings, Pharmaceutical and Therapeutics Committee. So they will say there's coverage for hepatitis, say C, and one of those is pharmaceutical products, but they won't determine which pharmaceutical products. They'll turn that over to the Pharmaceutical and Therapeutics Committee to determine based on the evidence around those drugs. And they have continued to refine and look at their process over the years since it first started. There is time for folks to come and present things to the commission. Providers do present their individual, sometimes needs for some certain patients about something that they want them to investigate. And it's staffed, actually, I oversaw it for many years, very small staff, but very strong collaboration with the research community in terms of pulling the literature for them through the Center for Evidence-Based Policy at OHSU. Next slide. Another effort that went on in Oregon, and I helped to staff long ago, was setting Oregon's benchmark plan. This evolved out of the passage of the Affordable Care Act, where we were setting up the insurance exchange. And so there was a process there of determining a benefit package. And I won't read all of this, but it was some background for you to understand where the benchmark plan came from. And it was thinking about the small group and individual market predominantly. And it needed to have the 10 federally required categories of benefits so that those on the exchange could get the premium subsidies and copay subsidies that were part of the that are currently existing in the insurance marketplace now. And it is regularly updated as well, trying with now a little more flexibility than there was back when we first started it, in terms of how we could define the essential health benefits. An example there is that you have to pick the plan that's picked, say, for instance, does not cover alternative medicine because it wasn't a 10 federally required category of benefit. But there are some plans that do cover it, but it wasn't that the benchmark includes it as a basis. And we'll get into how that kind of compares when we talk about benefits a little later today. Next and last slide, I think, is just about the prescription drug plan, long name, practitioner managed prescription drug plan, set up in 2001. And it was to come up with similar to the prioritized list for services. It was to make a cost-effective drug list for those on fee-for-service. The CCOs also look to this list. And they evaluate this comparative safety and effectiveness. And then because it's Medicaid, there's some unique features where that information is then taken in to look at what the costs would be. That is a component of it. If they're not on the preferred drug list, then they require a prior authorization. And then those drugs are not approved until reviewed by this Pharmaceutical and Therapeutics Committee. Rather than what often happens is a new drug comes on the market and it's suddenly covered by everybody, and then they find out later more information, and maybe much as Oregon did one time with arthritis medicine, found that there were some actual side effects that were not great. So Oregon has always tried to look ahead and tried to limit the use of brand new drugs until there was some good evidence that they were safe and effective. Next slide. And just a mention about the committee, again, volunteer, advisory, clinical, as well as consumer representatives, holds regular public meetings, have been making policy recommendations for some time, and work really closely with the OSU School of Pharmacy for their help on evaluating the evidence, and is run through the Medicaid program. Next slide, I think that sums up I don't know if anyone has any questions at all about the history, but we just wanted to set that as a grounding as we think about, considering whether there is potentially some sort of way to incorporate the long-standing traditions in Oregon around evidence-based decision-making around benefits. Chuck, you had
I have a question. So it relates to a bunch of things I think we're going to be talking about, but so with this, so who decides that if I want an MRI, that first I have to get an X-ray, then I have to get I have to go through physical therapy, then they'll decide that who decides that? Not that there's telling, I'm being told, and I realize anecdotes don't make data, but anecdotes show what the problems are in the current system, that I want an MRI for a soft tissue injury. And I'm being told, no, you first have to get an X-ray, which doesn't even show soft tissue stuff. Then you have to do physical therapy. So for the Oregon plans and whatnot, is the Health Evidence Review Commission saying you have to do these precursor things, or is that the insurance company that's deciding that?
Well, if it depends on the insurance, and which insurance you have. If you're on Medicaid and you're in fee-for-service, the diagnosis would be, low back pain, for instance. And so ideally there's diagnostic studies to help evaluate where, and that's something unique to the list, that a lot of the diagnostic studies are to help make the diagnosis that you have, what type of low back pain you have or whatever. So those aren't as regulated per se, although the commission and many organizations in the medical sphere have put out a lot of information about the evidence, saying that you probably don't need to rush to get an MRI scan for about 6 weeks unless you have these kinds of findings. And so it's really not a cost-effective, use of dollars, be it private or public, to get an MRI scan.
Who's making that? Is that up to each insurance company to decide?
So say you're in Eastern Oregon CCO, there would be probably an approval process to get that MRI approved because it's expensive. And so they might have looked at the HERC's decisions and guidelines and decided that you wouldn't get approved. And John.
I just before we go on. So
yeah,
I'll tell you, I'm on a Medicare Advantage plan. So some of the people have been telling me it's a Medicare rule, but I also tell you that the main reason they claim is because people get unnecessary MRIs and they're very expensive. And in trying to find out the cost, I was quoted $9,000 by one person. Same entity said, no, it's more like $3,000 or $4,000. And they said, well, I don't believe that you can get it through your direct care provider for $590, and I can. And so for me, some of the procedures that are required in eligibility that is being used today by the Health Evidence Review Commission and others and the insurance companies are based on sort of the false payment structure we have. That there's no reason I can go get an MRI for $590, but if I do it through Regents, Blue Cross Blue Shield, the radiologist is going to get paid $1,800.
Well, and the commission doesn't look so much at costs themselves. There's a lot of evidence also that getting MRI scans can show things that really aren't the cause of the pain. And so you go on through unnecessary. So there's been studies that have showed that sort of thing as well. That's unrelated to the actual cost of the MRI.
I know, but some of the process is based on frankly a false assumption about costs and false costs. Okay, the fact that the MRI that I can get one for $590, but if I do it through my insurance company, they're paying between $2,000 and $3,000 is ridiculous. Okay, and so that's. I'll leave it at that.
Yeah, let me just intercede here for a minute. Basically, when you get a medical service, the first thing that happens in an insurance company, they look to see, after they've established that you're a member and you're eligible and all of that, is it an excluded service? okay? Oregon's prioritized list is very much like an exclusion, okay? And that's one of its problems. And correct me or update me, Janine, it mostly focuses on treatments, not on tests, okay?
Right.
And it's been pretty much a yes, no, which is a challenge because, you know, take one of the old no's used to be the prioritized list did not cover hernias. And 99% of hernias don't need to be fixed. Although in some health systems, they're probably fixing half or more of them because they make money doing so. So the prioritized list is explicit. It's right there. It's easy to explain and understand.
Versus an insurance company doesn't always have as clear of descriptions. I mean, that's when you get at thinking
Right.
about transparency,
Right.
the list is much more transparent than a decision made in a back room
Right.
of an insurance company.
Right. Once you get past that, then you're talking about policy decisions that have been made by the insurer. In an ideal world, you would be able to ask, okay, well, you guys are giving me trouble about my MRI. I want to see your written medical policy about MRIs. And they would give it to you and say, you know, here it is. And the reason why we're denying this or we want authorization to be done is that sentence. You know, your doctor hasn't satisfied that sentence. And some people do a good job of that. Some people do a terrible job of that. Really, one of the questions for us is, can we design a single payer system that would do a much better job of that? And by the way, when it comes to testing, there are now more, like the U.S. Preventive Service Task Force, when it comes to prevention, focuses mostly on testing. And it can make a huge difference. You know, believe me, in New York, my wife had to finally get angry at her doctor staff because they insisted she have an EKG every time, every visit before the doctor saw her. And she said, you know, what are you guys up to? I don't have any heart problems. I don't want this. Well, you know, they were making $100 a throw. So, you know, this is a problematic system, but in a better organization who truly prioritized patients, I think you could get it much closer to right than we get now.
So I know I saw Dr. Metz, you had your hand up, and I think I'm going to go ahead and have you speak, and then I'm going to need to move us on just because we do have a lot on the agenda, and I want to make sure we have time for everything. So, but go ahead, Dr. Metz, and then we'll transition to the next part.
Thank you. This discussion is bringing up two kind of esoteric topics. One is QA. QA is not about standardized process, like how many x-rays you have to get before you're allowed to get an MRI, but it's to detect outliers. If one physician is if she's ordering 10 times as many MRIs as a comparable one, then there needs to be some internal accountability. We're also talking about the concept of financial risk bearing. If there is a physician who is spending an excessive amount on patients, who pays for that? Is it the patient who's demanding an MRI for a headache? Is it the physician? Is it the insurance company? Is it the hospital system? Is it some intervening entity? Wherever that is, what's really called for is internal policing in terms of QA. That is, why is somebody doing something excessively? They may have a great reason for doing it. Maybe we should be doing more MRIs. But I think that's what QA is about, and I think that's what risk bearing is about. Internal policing, rather than having the legislature, at worst case, tell physicians what process they should follow by statute.
Thanks, Dr. Metz. So I just, before we move on, and Glendora and Dr. Junkier are going to present some information and lead us in a discussion, I just want to reflect for a minute that what Janine presented and tying that to what we talked about in the beginning, and then also the comments that Dr. Junkier made, you know, I think where we're trying to get to here is what is some of the wrapping, what is some of the evidence wrapping that can happen for this proposal that this group is going to put forward, which doesn't necessarily mean, I mean, having that wrapping will keep us out a little bit of getting into the nitty gritty, like Dr. Junkier was saying, of having to enumerate every last benefit. And so I think having this, a little bit of this background, and as we move into the rest of the material, I'm just going to encourage everybody to kind of keep that in mind as what are the principles and what is the wrapping that the group wants to use and emphasize in putting another recommendation forward to the task force. So with that, I will put the slides back up. I think, Glendora, do you want me to put up that slide?
Yeah, please.
Okay, I will do that, and then I will turn it over to you here. 1 second. Okay, are you guys seeing my screen?
Yes.
Okay, all right, it's all you.
Okay, thanks, guys. First, I'd just like to thank, is it Jean or Janine? Jean, right? I'd like to thank Jean for that comprehensive overview of the status quo system. And those elements that Jean talked about are what's wrong with our current healthcare system. So what I base these considerations on, what should a benefit package look like, are these following considerations. So to keep the story short, because I don't want to go 10 minutes, I could go perhaps an hour on each of these. I just want to remind us that if we reflect on the EBA as being the underlying principle of what a comprehensive healthcare plan should entail, we need to be focused on all of those elements that Jean talked about, focusing on the quantity, quality, and cost, because those are the driving forces behind the decisions that are made when we have to develop prioritized lists. Prioritized healthcare services lists are a bunch of subjective input someone thought that were necessary. And my thinking, because I'm from a grassroots, I'm thinking from a grassroots level, is that they're prioritized because they help control the costs, and they are based on private market profit and limitations, and when it comes to the cost. So if we can think, I'm going to wrap this up, because I'm sorry, I'm going to wrap this up in saying that what these considerations reflect are three areas of our healthcare system that we should focus on in developing a robust and or comprehensive benefit package plan that is not going to be subjective in nature, but it's going to be all inclusive. And we should reflect on this because there is the need to use that equity lens. And if we do not understand the equity lens and what it implies and what it needs to for us to develop a design that is beyond limitations, but a comprehensive in nature in providing services, we need to think about how the services will reflect quantity, quality, and cost. So that's what I want to bring to us today. And that's what these considerations are about. So if you have any questions as to how those things will meet the socioeconomic tangible benefits for marginalized people that's going to serve all Oregonians on an equitable and equal basis, then I'm at your disposal. Thanks for listening. So I'm going to turn it back into the hands of, is it you, Sarah, or Xenia? I'm sorry, Xenia.
Yeah, I don't know what else I can add. You know, I have some thoughts, a few of them that I was able to share a little earlier. It doesn't feel like the place and space to share them right now. So I think if you want to take us into the activity, Glendora, I think we can absolutely do that. And then maybe some of the additional conversations will come up about, you know, how we do some values alignment here and how we ensure that, you know, the goals of this particular tag are not only aligned with the values laid out in SB 770, but also as the values of the task force and the ways in which those values in action are at play.
Okay, so if anyone wants to read those bullet points and weigh in on what they mean to you, how you see them unfolding, what benefit it would be to all Oregonians, then by all means, go ahead. If you want me to expand on them further, let me know. Otherwise, I want you guys to share how you think these areas will benefit the design model in addressing equitably and equally healthcare services for all Oregonians. Let me ask you a question. Do you understand the point what I'm asking you to do or contribute and reflect your thoughts about?
I'm a little confused.
Okay, so what I want to happen is we all understand what socioeconomic tangible benefits are, right? So we are talking about how those or lack of those services will impact the health conditions of and health services built into a benefit package that is comprehensive, meaning we have no limitations, meaning we treat everything based on the recommendations of the patient and provider agreements, diagnostic treatment, what they agree to, what the patient's willing to do, what is the cultural consideration of the patient, how it will impact the cost of the healthcare services delivered, that kind of thing. And so if the public understands the hands-on benefits from a comprehensive healthcare services package, for example, Chuck was talking about why does he have to have an x-ray 3 or 4 times over a period of time before he gets an MRI. Well, that is from a health economics perspective, that is to control costs and its profit. Because if a million Chucks have to go through this private market insurance-based policy of having to wait before they get the diagnostic testing that they need, how much money would that save the insurance company if they have to wait 3-4 months out for like 1,000 people and stuff like that? So these are the kinds of limitations that are placed on our healthcare services benefits provided by either the public, Medicare, Medicaid, or the private insurance companies. It's a manner of controlling costs, and they do it at the expense of denying patients or health consumers access and to quality care. So that's the
Glenn,
point I'm trying to make.
yeah, Glenn, there's nothing on this slide that I would disagree with, but it describes a perfect world. And we're not in a perfect world, and we're not going to get to a perfect world even with a single payer. I'm sorry, I suspect you have a sense of this. My experience is we currently have at least 10% of healthcare providers who are opportunists, profiteering. You know, good gosh, we've had 900,000 people die because of the behavior of a single drug company, Purdue Pharma, and a substantial number of physicians who wrote those prescriptions. Those were written by clinicians. We're not in a perfect world. And, you know, the next slide would need to, for me, to say, but knowing we're not in a perfect world, here's how we're going to do our best to be transparent, to steward our resources, and protect patients. Patients need to be protected from healthcare systems that are profiteering, are harming them. We have 2 million hospital-acquired infections a year, 2 million, and they're preventable. They're 100% preventable. You know, I love Xenia's suggestion, and actually was involved in an effort in 2012, a benefit design effort that recommended a community of people the community of people should come together and further design and on an ongoing basis keep track of what's working and what's not. And the group I was in had folks who had done that. It had been successful. Communities can take on a perfect world proposal like this, accept that we don't have a perfect world, and make the hard decisions that need to be made.
Thank you, John. I would just say this. We, none of us, because we don't walk on water, can make suggestions based on a perfect world, because we all know better. We've lived long enough to understand that. But what I am saying is that to be innovative in our thinking and thinking beyond the box does not require some sort of expectation of being in a perfect world. I think the services that we have now and the systems that's been set up is perhaps maybe because they didn't plan as though they could achieve a perfect environment. But because we know that our efforts will never be perfect when we're designing subjective, when we are designing models based on our subjective viewpoints and our lived experience, because these are social concepts and they're always going to be fluid and they're going to change with time. And no one individual can identify a set of standards or rules or practices or policies that's going to work perfectly. So we are designing and attempting to think about areas of where we can improve the health outcomes and provide unlimited services as needed based on the physician and the patient, such that they will not be denied. They will get timely care. They will be walk away satisfied. They will have opportunity to make freedom of choices, and they won't have to rely on being within a network versus not within a network. They won't have to rely on third parties insurers who are competing against each other with the primary focus on profit over people. So this is where I'm coming from when I thought about these considerations. So that's all I'm asking you guys to do. Not forget about that perfection. We're not going to even entertain that thought because nothing is perfect, right?
You know, Glenn, I mean, you use the term services needed. I mean, let me share with you that I once remember my staff asking me to call a wonderful surgeon. He had come to Portland, recruited to come to Portland. He was an ear, nose, and throat doctor. He did incredible research. NASA had millions of dollars of research contracts with him. He thought that a particular surgery he could do would help people who had balance problems. The case that I was asked to talk to him about is he wanted to do this surgery in a patient that he had done the surgery on 16 times. He had done the same surgery 16 times. And he was asking for permission to do it a 17th time. I didn't think that was needed. I didn't think that was appropriate. You know, you use the word needed. You know, it goes back to Sam's medical necessity and his withdrawal of that. I mean, in the real world, you have to have an approach that's transparent and responsible to figuring out what's needed and to inform both patient and providers of that. And that can be done. But it can't be done if you start out with terms, there's no limits, there's no restrictions. You know, that the decision comes down to what a patient and a doctor want. You know, again, I'd go back, it should come down to what a community, as Xenia, I think, was describing, considers at a given time to be reasonable given the resources they have. You know, this goes back to the commons. You know, in the East, there's these commons in the middle of every town, because it used to be that they, you know, everybody could graze their herd. Well, you know, some people took advantage of that. They just put as many cows as they could in there and wiped out the pasture. That's human nature. So you have to have a process that makes the kinds of decisions for the common good. But that's not just going to happen. You have to engineer it. You have to do it. And that's what we're talking about here. I think we have the same goal. It's how do we get to it?
I think the difference is our worldview, our perspective. And that is, you're speaking from in my lived experience, from old school thought. Now we're in the 21st century, and the upcoming generation of physicians are not thinking along limitations unless they have a specific reason for it, which is one of power and wanting to be the sole decision maker in their patient's care, rather than making decisions with their patients and not for their patients, based on perhaps implicit racial bias, because they think a patient is incapable of understanding for many reasons, right? And racial bias is one of them. So what I am saying is that we need to think from a holistic perspective of how the services and limitation of services will impact the quantity, quality, and cost of the healthcare benefit packages. That's all I'm saying.
I'd
I
like
hope you
to,
can understand that.
Cheryl's had her hand up for a while. So Cheryl, do you want to jump in?
Yes, thank you. So first of all, I am totally on board with the values that you have listed for benefits. And I love the idea that services would be determined based on what the individual needs and not on the bottom line of the insurer. Yay, that's great. I think I'm on the other end of the spectrum to John in terms of concern for getting too many services or services that you don't need. I can't even think of an example in the behavioral health world of people who are getting too many services. We need more services. So it's hard for me to even imagine that. I think really my reason for being here is very practical. I want to know if the benefits that will be covered for behavioral health are comprehensive, or are we going to need to continue to rely on state general funds and other taxes? Well, if all the taxes are thrown in here, I guess that's not an option, but other funding to cover behavioral health services. That's why I'm here. I just want to make sure that we're not doing this like Medicare for all type of plan that is not good for behavioral health. And in that case, we would need to be very honest with the people we serve and our providers that, you know, this still isn't getting us to where we need to be. And so that's what I really want to know from this group, what's going to be included in the benefits package for behavioral health, because what I saw during the task force meeting was a very narrow benefit for behavioral health. So that's really why I'm here. And I just want to know what's included. And if we have a plan B for covering those services if they're not included in the single payer system.
So I just want to say that, yeah, thanks for that, Cheryl. Glendora, I don't want to cut off your discussion. I know that we're running about 15 minutes behind. I don't think we have any public testimony, so I think we're probably okay, but maybe just a few more minutes and then we'll wrap it up and go to our break. Dr. Metz, I think you had your hand up.
thank you. I hear Cheryl. We need to cover behavioral health like we do every other frontline primary care service. If we're going to stint on services, it should be in the neurosurgical realm, not in the front door realm. I'd also like to pick up on some things that John was alluding to. I make a distinction between comprehensive care and unlimited care. What makes American healthcare the most, you can die of bad care in any major industrialized country. We are not unique. The United States is the only country where you can die of no care because you don't have the money to get into the system. Our work can remedy that. That is what we bring. We know that the most expensive patients in the United States who drive up the cost of healthcare for everyone, and we know the ones with the worst outcomes who make our public health and our medical outcomes the worst in the world are the patients who don't get care until it's too late. I think we should focus on the benefits that bring patients into healthcare to begin with, to make sure that the impediments are not into the entry. We should have less attention on what happens in tertiary care, et cetera. If we can get patients into our current crummy, inefficient healthcare system, we will save lives and Oregon will benefit from it. This is what our single payer task force can bring.
Just quickly, I'm appreciating this conversation, and it's bringing me back to a point that I had written down, which is, you know, in some ways we have been asked to do kind of an impossible task and an impossible timeline, and I've been part of enough task force to know that these timelines are often not long enough to be able to do the work that we need to do. We're asked to do it in a really short and condensed timeline, and then at the end of the day, you know, we don't have time for these conversations, which are really important. So that's one thing. I really appreciate, Cheryl, your point, and it makes me think about the need for this task force to do a very global analysis and to have some enumerated benefits, because I think from a naturopathic perspective, I feel very similarly that, you know, at the federal level, we don't have any sort of like federal standards, and so we're going to lose the ability to like receive an enumerated list of services there. As state by state, you know, the state already doesn't have necessarily a list of services for alternative medicine that are you know, standardized, and I can see how there are probably other fields of healthcare, you know, healthcare and ways in which healthcare is provided that also will fall through gaps if we aren't really clear about what those services are. So I appreciate your point, because I think that it's, again, and I guess to go back to my initial comment, we are being tasked with doing something that is, I wouldn't say impossible, but is very hard. Though I think we need to address the needs that our task force members are bringing up. And I think, you know, Janine, I really appreciate you setting the stage for us about what exists currently. I think I'm in a little bit of alignment with the ways in which Glendora, not a little bit, a lot of it, Glendora, you know, talked about the fact that, you know, I had this visceral reaction to this like evidence-based practice and the continued use of this language, not only here, but in general to affirm certain practices that I think haven't always served BIPOC communities, low-income communities, disabilities communities, et cetera. I think we often use this term evidence-based as if it's objective and it doesn't have any sort of ways in which it can be oppressive. And I don't believe that to be true. When I look at the HERP committee, when I look at the pharmacy committee, there are no naturopathic physicians on there. Almost everybody is a healthcare provider, MD, DO, nurse practitioner, et cetera. The 2 community slots are filled by, you know, healthcare providers themselves, et cetera. And so I think about all the ways in which, if we really want to do something that's grounded in, you know, the needs of community, we've got to have community voice there. So John, I'm interested in learning more about the work that you were doing. I think in this space, maybe not the conversation, but if you're open, I'd love to reach out, because I do think if we're trying to do something that's never been done, we have to be really creative, and we can hinge on some of the places that feel like they've been successful for us or for other states or even internationally. But I think a lot of this is going to have to be created. And so I worry too, if we spend too much time on like grounding in what we know, we may not be creative enough to get something out that truly shifts the landscape of healthcare in Oregon, and at the end of the day can get passed. Because if I go out to community and I show them a list of services that don't include services that they need, do I think that they're going to advocate to their legislator, or that they're going to vote for, or that they're going to get their community involved in advocating to change the ways in which we engage in healthcare? Absolutely not. So I think there's a lot going on here, and I just want to remind us that the goal, I think, was not by June that we have some fleshed out plan with a list of benefits that goes to the legislature in a neat bow, right? When we were really hoping for some more time to do this, and I would just ask us to take the time that we need so that we don't put forth something that ultimately doesn't end up working for anybody.
Yeah, Dr. Jenkins. And then I think we're going to try and wrap up and go to a
Yeah.
quick break here.
I was just going to say now it seems like a good time for a break. And, while we're on our break, I appreciate all the conversations and the perspective. And I want to go back to one of the 3 points I put up on the opening slide, which is, how are we successful? And we don't have to be in agreement. It may be a minority that puts it forward, but we need a clear recommendation. And I'm hearing talk about stuff that we are in agreement with, and I'm hearing talk about reality. I'm hearing talk about evidence-based, and we need to come up with a recommendation. So as we are saying these things, I agree with all this stuff, and I keep thinking, what are we recommending? What does that look like? Xenia, Glendora, Sam, John, what do these things look like? Because somebody's going to have to ask that question at some point. And timeline wise, it may not be now, it may not be us, but it's going to have to look like something, because right now it looks like a all benefits included package that the group 2 weeks ago, 3 weeks ago turned down. So we've got to do something, or we're going to put that same plan right back in front of them. So I just wanted to put that out there, because I keep saying, what does this look like? We need something tangible. And it's hard. And that's how it is, because it's going to be hard for somebody. So it may as well be us.
Thanks, Dr. Jenkins. So I think it's a good time for everybody. Let's just take, since we're extending our meeting today to 3 hours, so let's just take a 5-minute break, and we'll come back out about 2:28. And yeah, get a glass of water or whatever. Thanks.
Hey, Glendora, it's Oliver.
Hi, Oliver.
Hey, I just want to check in with you. I know we're trying to get some time with you and Dr. Santa for Wednesday, and I know flurry emails going around. I thought since I have you for a moment on camera to see if you had any time on Wednesday to connect.
Yeah, I sent you email. And so whatever time you set, I'm open Wednesday.
Okay, so you're no constraints on Wednesday then to get you and Dr. Santa in a meeting.
Right.
Okay, great.
And also in that email was a replacement question to fill that 30-minute gap.
Okay. Yep, I'm just waiting for you and Dr. Santa, or we'll do it on Wednesday to figure out exact wording or how you all want to proceed on that.
Yeah.
Thank you.
Okie dokie. Thank you.
In a little bit here, and I think that conversation and discussion y'all had, you can kind of keep some of that in the back of your brains or in the front of your brains as we're going through more of this, I guess, a little more cut and dried material. Janine's going to present. We're going to have a discussion, and I think to Dr. Jenkins's question towards the end there, try to elicit from you all, what is it that you want to put back to the task force when they meet in April? So hopefully this latter half of the meeting, that's really the goal, is to figure out what do you want to come out of this group and get sent back to the task force in April. So I'm gonna share my screen again and then turn things over to Janine.
So just wanted to kind of do a little thinking about, if we think about that, you had the proposal, and I think from our conversations with Glendora and Xenia, we talked about that was sort of like version 1. And so is there a version 2? And so wanted to kind of walk through some aspects that you might consider, many of them potentially more of a wrap per se than going down into the specifics of every benefit category. But what you proposed before was basically the Public Employees Benefit Board package, but it removed all of the cost sharing and any of the limitations, except in a few categories where you had where you noted you would do some limitations around a certain particular benefit categories. If you were thinking, well, maybe we should use a different benefit package as our basis, we thought through, and that's why I had put the previous little snippet about the Oregon benchmark plan that's used by those on the individual market, those getting subsidies through the marketplace. What about using one of those? And those are basically the same set of benefits, but they apply, as we had our conversation earlier, some medical necessity parameters put on by the health plan. And they also don't include all of the benefit categories. Particularly notable is complementary or alternative medicine, such as naturopathic, chiropractic, acupuncture, and they don't include vision or dental for adults, although they are required to cover for children. So you have to buy those as additional benefit wrap. The Oregon Health Plan, as we talked about, has their same set of benefits, but is then their parameter or wrap around their benefits because they're taxpayer dollars that are being limited, finite amount of dollars put towards it, with some of it being a percentage of it Oregon taxpayer dollars and the rest of it federal matching dollars, have come up with a prioritized list and guidelines of which they use a variety of evaluations to kind of narrow down inside each of the benefit categories. So if you really, as an example, all of them cover hospital inpatient services. You have to, in order to qualify for the subsidies under the ACA. You would cover it based on your first proposal with no limits and no cost sharing. The benchmark plan would cover it with no limits, although there may be situations where the health plan might limit your use of the services there. For hospital, might not approve a 20-month stay or something like that. And then OHP would, through Open Card and or CCOs, some of the services you might receive inside that hospital stay might be limited based on the diagnosis you have. And the similar for cancer care, very similar with different interpretations. Next slide. And then there was some discussion about medical necessary services. And Medicare defines that as those needed to diagnose or treat an illness, injury, condition, disease, or its symptoms that meet accepted standards of medicine. And in 770, there was there's notations in terms of that the criteria to determine which healthcare services are necessary, whether the services are cost effective and based on evidence from multiple sources, whether your benefit package that you are putting forward is similar to or based on the Oregon Educator Board or Public Employees Board, whether you're going to be aligning or connected to some of the these various entities here, the United States Preventive Services Task Force, which looks at evidence and sets guidelines, immunization practices, which we've gotten rather familiar with since they started with COVID, but have been around for a long time, setting the parameters around immunizations, especially the children's immunizations. And health services, HRSA, Health Resources and Services Administration, Bright Futures, which is a lot of a focus on children. Institute of Medicine has its set of preventative services focused on for women. And then the Health Evidence Review Commission, which I didn't add, but they do take a portion of it, just to note the previous conversation of looking at the impact when they rank based on vulnerable populations that might have a unique and need versus another part of the population when they're thinking about the ranking. And so then there's this word evidence, which is, is that part of it. And then there's also whether it's services are based on information provided by the Traditional Health Workers Commission. So those were sort of your, the parameters or wrap that 770 had offered for you to consider as you think about your benefit package. Next slide. So we put forth this just as a consideration, but is to consider, ensure that the care delivered. Do you want to say, okay, here's our benefit package, but we want to ensure that the care delivered through that benefit package is evidence-based and appropriate, medically necessary. Some potential, if you want to go that route, there's some potential language that we would propose. So the benefit package would include those benefit categories based on PEB. I think that is more comprehensive in terms of service categories than if you switched over and wanted to do the benchmark plan, because many of the discussions that we've had over the years around Medicaid is how the mouth is connected to the eyes, which is connected to the rest of the body. And so the more comprehensive benefits of including dental and vision are really important, and we've seen critical for people to even get jobs and be able to really live a full life. And complementary medicine, there is many parts of the prioritized list where there is some coverage for various of the complementary and alternative medicine services. And so in Oregon, that is something that a lot of people really need and has cut down on opioid use and other. So I think that we're suggesting that you could continue to use the PEB proposal as your baseline, but then adding perhaps that there is some specific guidelines for each benefit category that would be evidence-based as determined through a public and transparent process like that currently used for the health plan. Not saying that it's the perfect plan. Many states just arbitrarily set it. At least Oregon has had a public process around some of this. And it doesn't mean it couldn't be further improved or add a more of a community members as per your previous discussion. But it basically is kind of adding, yes, we're going to stay with PEB as the basis for all the categories, but then each category, that would be refined, and rather than at this point being able to really do that, and with the limited time you have, is just suggesting that there would be some process that uses evidence, that uses input from the public, that is transparent. Everyone knows what's happening, what's there, what's not, as a basis. So I'll stop there and we'll open it up for some thoughts and discussion. Sam? Sorry, I didn't see you.
That's okay. It's the 21st century.
I know. As I keep trying to get the little strip to show me so I can look at everybody's face.
I like what you have outlined here. We have a basis, PEB, and then we're modifying it. What the various complementary services have in common, the dental, vision, complementary medicine, et cetera, is these are all primary care services. They are all, relative to a lot of other kinds of medicine, inexpensive, and they are the first step for patients trying to get into the system. So also people are already spending money on these things. So folding them over doesn't change people's discretionary income. And I also like the idea of using a benefit priority list that Oregon has already processed. That wheel is there, we should use it, and then build in some sort of mechanism for continuous rethinking of this. But as a starting place, I like what you proposed.
Other thoughts?
Yeah, Jane, this is Glenn. I'm thinking that I'm not usually an either or, but a both and. So I was thinking that perhaps we might consider the benefits package plan to include the existing essential health benefits required by the ACA, as well as those described as the Oregon benchmark plan and in the Oregon health plan and the PEBB plan. So that for me, I think may be a good start on focusing on an innovative, approach in providing and in including in the benefits package plan.
Glendora, this is Sarah. I just want to make sure I understood what you're saying. Are you suggesting we would incorporate all of those?
Yeah, I'm suggesting we perhaps consider including all of those EHB benefits required. That's within the ACA. This is I'm having this vision of comprehensive, all-inclusive services without limitations. We can always hash out, other things, but to start with, because each of these things have different advantages and disadvantages. So all three, the EH benefits required by ACA, the Oregon benchmark plan, those services identified in the Oregon health plan, and PEBB. Now, I happen to know that PEBB is provides health benefits that are more lucrative and than those of the Oregon health plan. So that's why I say, let's consider all of those services that they have in their plans to present as a comprehensive benefit package. Does that make sense?
Yeah, I think what my first slide had shown is that basically all of those plans have the 10 essential benefits. So you would qualify for the premium subsidies, and that the benchmark plan, the Medicaid OHP plan, and PEB all have the similar set of benefit categories. There's some specificity within and how each of those three plans handle those benefits. So I think we're kind of on the same page, is that if you picked PEB, you're really getting the ACA requirements and you're getting what's in the benchmark, but you're also getting those things that aren't in the benchmark, and you're getting everything that's in the Medicaid plan. It's just how we, and that's where it goes to that second line, is how do we handle those benefits inside each of those.
Okay, and with those, I also think that we eliminate the annual or monthly deductibles, premiums, co-pays, and co-insurance payments, and no cost sharing.
Yeah, well, we can get, we'll get to that a little later today to confirm that that's where everybody's at. But yeah, was part of your previous one, was to get rid of all those cost sharing, and that was part of version 1. So, but as far as benefit categories, sounds like you're kind of in favor as long as all those things are sort of captured in the basis of the plan in terms of categories of care, not so much how we do them yet. So,
Yeah.
Other folks' thoughts?
This is Enya. Can I ask a clarifying question? I don't know, Sarah, if you can go back to the slide. I'm wondering if I heard the ask right, which is around supporting the potential language shifts about the benefits proposal. Is that what you're asking us if we are in agreement with or not? And so we are talking specifically or speaking specifically about the benefits package, saying we need to discuss dental, vision, alternative care.
What we were proposing was that you had proposed a budget, a benefit package with all those benefit categories as per PEB. And we're saying, we're just confirming that that's where you still want to go today. Because if you chose, I'm just giving you the option that you could flip to having just the benchmark plan. But then we would have to have a discussion on whether you would want dental, vision, and everything that's not in the benchmark plan. But basically the essence of all this is that all those plans have all the same set of benefits. It's just a matter of how they're interpreted and how they're provided to people. Because on the end of the slide deck that we passed out is where Sarah is showing us, your proposal is the one highlighted in the center. Like complementary medicine isn't required for an ACA subsidy, but we, in your version 1, said, yes, we want it covered. The benchmark plan, it's not included, but OHP it is. Your plan was based on PEB, it is included in PEB.
Okay, thank you for that.
Right. So again, getting back to Ed's, what are we going to be proposing? It sounds like, so far anyway, that Glendora and Sam has suggested that you're okay with using PEB as your basis. And Glendora want to make sure that all the other aspects of the other plans are in there. Which we just
make one modification about PEB, and that is we omit specific statements that say no limits. I believe we should add limits on a benefit by benefit case, but we should not guarantee for any benefit that there's no limit.
Thoughts from others?
Dr. Santa has his hand raised,
Okay.
and Cheryl also.
Yeah, I think Cheryl, I think you may have been first. No? Okay. Well, first of all, I would agree with Sam. I'm going to be a lot more comfortable with that no limit language out for now. Because I just think that can easily provide an expectation that isn't realistic. What I mostly wanted to clarify, though, is there comfort with the U.S. Preventive Services Task Force recommendations, the Women's Health recommendations? Those are in the Affordable Care Act.
They're also the things that the prior HERC looks at in determining their work.
Right. That's a perfect example. If we follow the U.S. Preventive Services Task Force, it's going to be very easy to sit down with primary care doctors and negotiate a payment arrangement. If we have to sit down with them and say there's no limits on prevention, they're going to be looking at us like, what? How do we figure this out? I'm hoping everybody's familiar with USPSTF. It's been around for 4 decades, I think. I think the medical, albeit the traditional medical community, has come to, I think, respect its work. It is evidence-based. but I think sets a reasonable limits on what's preventive.
So examples of that for others are when you should get your colonoscopy, at what age, whether you should be being mammogram screenings, at what age, a variety of situations. When should you be doing screening for suicide prevention, if you think about it from a behavioral health perspective, that sort of thing. And they look across the literature, various populations, to try to get to that, and a lot of input and public input into their final recommendations, as one example, as do many of those other ones listed in 770.
Cheryl, did you have a comment? Or
Yeah, I have a question on the essential benefits. Believe it or not, I sat in on those essential benefits work group meetings, both for the insurance side and the Medicaid side. And so I know about that process. And what I've seen is that the way that they're operationalized is that Medicaid benefits are a much wider service array for behavioral health than insurance, commercial carriers. So I'm wondering, I don't know much about PEB. Is that more of a commercial insurance type of package, or would you say it's closer to Medicaid?
I would say it's interpreted by each of the vendors that the PEB board contracts with. So you've got MOTA plans and Providence's interpretation of it, and I think it's the Providence is the statewide plan. And then there are, I think, still a couple of the CCOs are providing PEB benefits as well. So it's a little more leaning, Cheryl, probably towards the commercial interpretation. I know the Providence plan outsources its behavioral health management, and it's to another vendor under them for the benefits for mental health. So
it really depends on the carrier then.
Right. But that doesn't mean in a single payer that you couldn't define it more encompassing. I mean, I think that's the essence of the prioritized list, was that everything was integrated, as you well remember, over the years, where if you look at the list, it isn't like a list of medical stuff and then there's the behavioral stuff. It's all integrated in the prioritization to encourage the treatment universally, as dental is as well.
Mm-hmm. Okay.
So Sam had his hand up. Anyone else? Am I missing anyone else's hand?
before we move on, Cheryl, I wanted to kind of see if I could get at maybe a kernel of where that question is coming from.
It's my same old.
No, I mean, I got you. I'm just trying to get a sense for like, what would be a statement or a recommendation that you might want to see that would tilt this more towards, I think what you're saying, more towards like an OHP style than a commercial style.
Yeah, that's what I'd like to see. So it wouldn't be limited to in-office therapy and inpatient. It would be a much wider service array. If you remember that behavioral health reimbursement graphic that I sent everybody, you can see what's not covered by commercial carriers and Medicare, and Medicaid is just the better payer in terms of the service array, and even the providers, the types of providers. So that's what I'm wondering.
So to try to mirror the behavioral health benefits of OHP.
Yes.
On top, layer that on top, which gets back to Glendora's, right, of layering the best of everything into. So
yeah.
Thank you.
Sam.
Thank you. I think, Janine, you just articulated one of my points, which is our benefit plan should allow anyone in OEB or PEB or any of the government programs to join our plan and not lose benefits. So it should be the best hits of all of the benefit plans, at least in terms of enumerating what the benefits are. Also, John mentioned the USP, STF, Women's Health Commission, et cetera. I am not familiar with them, but if I understand the point, then I think there's benefit to bringing structure from nationally recognized programs into our program. I'm not sure what the value is or who benefits or who doesn't, but I think that adding structure helps people understand our program and adds validity.
And Xenia?
Yeah, I wanted to ask about the USPSTF, Women's Health Commission, et cetera. If there's a way for us to see which services we have named that we would like covered that have not or are not discussed in those federal spaces. I think about, we've got, again, robust alternative medicine, community, and here in Portland, not only community, but also regulation in the legislature. I'd want to make sure that we have access, that folks have access to services. I think about ensuring there's alignment with traditional health worker workforce. I think likely at a federal level, we're not going to see standards that we can follow there. I think we've got really amazing, gender affirming services and care here in Oregon that may actually be far more robust than any national task force on gender affirming care has offered. So what I'd like to see is if we're going to follow any frameworks that are federal or from other states, I'd like to see listed out what is missing there, meaning what do we actually not have either evidence around because it hasn't been designated by that particular group, or that inherently may lose out on particular services if we just follow that model.
And John?
Yeah, we can, I think we can do that, Xenia. In general, USPSTF is pretty traditional medicine oriented, pretty oriented to tests, screening tests, et cetera, which can have implications. For example, it does not advise coverage of screening carotid ultrasound because of the morbidity of endarterectomy in asymptomatic carotid occlusion. So it's very medical, and I doubt there's much there, but I'll take a look. I mean, it looks at hundreds of topics. The point I wanted to make is that likely CMS would come in and say, we're not going to pay for prevention that the USPSTF says doesn't work. Same with the women's health. You have to remember we've got a federal partner here. So I think including those will likely make the negotiations with the federal government more friendly. I should say, though, that Medicare has, interestingly enough, a preventive benefit or two that the U.S. Preventative Services Task Force doesn't endorse. So it's not a perfect match when it comes to the federal government. But they're very transparent, and I'll try to take a look and see if I can give you a sense of that.
But I think Sarah, if you wanted to show the slide with the second bullet on it, I think what we're getting at is there's a lot of this stuff, and having some structure such as the HERC, spends a lot of time going through all this. Some of the reasons that they cover acupuncture, for instance, is based on an exhaustive look at the literature that showed there was evidence, and many of the low back pain stuff that wasn't covered for years is now covered, including chiropractic, because of an exhaustive look at the literature. So, and looking at these various entities like I can never say it, USPS, anyways, yeah, and the Institute of Medicine and. So I wanted to get a feel that in order, rather than one-offs, there's probably other, some people look at the Cochrane Review, which is what England uses for their universal coverage program to decide what's covered inside their benefits. So I think what the second bullet here is suggesting is that there's some structure around this, using all of these sources and more, and thinking about, for instance, Oregon is more progressive than, say, lately Arkansas on trans care, based on evidence that they found in terms of 40% increase in suicide in teens when they weren't getting their treatment for transgender surgery. So I think that there's been, again, we are out there in front in terms of thinking about these things and using public need and input into making some of those decisions. So, what is there thoughts about that second bullet, whether that is something that there would be some guidelines or structure around each of the benefit categories to take the best of the best, as we just talked about, use a public, transparent process. And I just had put in there similar to what we've done, but not necessarily the end all of what, could be better and go further. Glendora.
Yeah, Jane, I have a question. I don't know what the justification is behind these limitations on the USPTS services, but one thing for sure that I'm thinking of when I think about this and the females and the age range is how many non-white individuals are were included in this in this evidence-based practice. In other words, when I see age limits, I want to know how that impacts non-whites.
Yes, and historically, unfortunately, not the studies are not as diverse as we would like them to be, and certainly not as we go. We hope to see more evidence going forward, and they do identify whether there's gaps in the research, and for folks to inspire the researchers to go look a little deeper on some of those. So it's also in transformation, so to speak. There's now more patient-focused research than there used to be, thanks to some changes that came in through the ACA. But I agree with you, Glendora. The evidence is not perfect. Again, getting back to the not perfect world, but they do try to dive in, just like the Health Evidence Review Commission, when they're doing their ranking, there is a category of, well, is there an impact on a vulnerable population here that we need to take into consideration that puts this higher on the list because it's really important for that population. Well, it may not be that important for the not, for the white population that we traditionally always look for. So,
which is why I am not a strong advocate for limitations, because many of these evidence-based practices have not, non-whites have not been represented. And so when we start limiting services, then we are excluding populations.
But I think you could give some direction moving forward that you want to encourage and expect more and more. It's a matter of somebody funding those studies, but hopefully that there would be a heavier, at least an overt look to see what can be known and where there's best practices that could be maybe not have full level of research yet, but are starting to show that this is important for the for non-white population particularly.
Yeah, I think
we can only get better. We can only get better going forward.
But yeah, and if we don't include this thinking in our measurements, then we're not going to get better. We're just going to keep applying the status quo based on dominant culture's perspective and understanding, recommendations and considerations. When you have lived these lived experience to in these areas, then you come to the table with a different perspective. And so if we're going to try and achieve equity in our design, this is the kind of critical thinking that I believe would be conducive to our design, so that we don't leave out any ethnicities based on fear of cost, because it all implies quality when we think from these underrepresented demographics.
Xenia, you had, yeah,
Yeah, I think maybe John, did you have your hand
John,
up?
did your hand go up first? Sorry.
Yeah, Glenn, I'll send you an article just published a couple months ago about how the USPSTF is changing the way to do things to respond to equity concerns. There are some important things to do. Some of it also, though, has to do with how we set our standards for what's successful. Oftentimes when it comes to prevention, we kind of shrug our shoulders and say, well, 80% of people have gotten a mammogram or a pap smear or a colonoscopy. So we've done our job, and we walk away and we don't ask, well, maybe we got a problem if the 20% who haven't are predominantly African Americans, which I think is oftentimes the case. And true equity comes when you do everything possible to see that 100% of people get what they need when it comes to prevention. And that's doable in many cases. So again, there's better ways to do things that I think it would be great if we could focus on. By the way, sadly, we recently, the Metrics and Scoring Committee decided to not incentivize screening for cancer of the colon because, well, we've been doing better at it every year for 3-4 years. We're up to 70%. That's good enough, and it's going to happen no matter what. And, they weren't concerned about equity issues, and I think they should have been.
Yeah.
Xenia?
Yeah, I just want to build on the statement I made earlier around evidence-based best practice. And I just want to clarify that I'm not against evidence, nor was I, trained in a way that allowed me to ignore evidence-based best practice. I wish that there was some more balancing of the stories from community members and individuals themselves, right? Because that's also evidence. And when we say evidence-based best practice, but that's only done by a particular body via certain funding streams or access to funding streams that are often not at all connected to any sort of efforts around, ensuring equitable outcomes, anti-racism in medicine, et cetera, that we then end up trying to use evidence-based best practices in a vacuum and not look at how we got to those evidence-based practices, who informed them, how they were informed, et cetera. And so, I think if we're going to say things like earlier, there was this comment, we don't live in a perfect world. I agree. If we live in a perfect world, we could look at evidence-based best practice as something objective, but we don't live in a perfect world. So we can't look at evidence-based best practice as objective because it's not objective. It is completely subjective, right? Based on who has access to the funding, as you mentioned, Janine, who is doing the research, what research is able to be published, who's publishing it, who's citing it, all of the pieces in there are subjective. So I think if we're trying to, be as objective as possible here, just an acknowledgement that the places that we're like hinging on are not fully objective in any way. So we, I think, can be doing a really strong job of being creative about what we like hinge on, and then where we ask for a little bit more so that we can develop something that's, you know, potentially more equitable.
Yep, agreed.
So I know time is ticking here, so we have a couple more areas to get to, but thinking back, so it sounds like the benefit package based on the PEB with the best aspects of the other plans that we've discussed, particularly around mental health and substance use disorder, being more mirroring OHP. Seems like that is resonating. Yes, no?
Well, I'm thinking OHP has such limited coverage of benefits. I wouldn't just base the mental health services, comprehensive services on OHP alone. So I would have to, I agree with Cheryl that there should be some additional focus and attention to mental health services, because we're so underrepresenting and limiting the kinds of services based on the type of mental illness the population happens to be dealing with. So let's make sure that the mental health services not only includes the expansion of services indicated in Oregon Health Plan, but also the other two as well, because then we could be more comprehensive in our focus and provision of services.
Glendora, one of the things, and this actually just a general comment, I think, is that in our original recommendations, we had a kind of a section at the bottom that called out additional items that the tag raised as being important. And a lot of them were related to like delivery system issues, like how care is sort of delivered and monitored. And I think some of the things that are coming up in this conversation, I just want to keep in mind that we can capture all of these in a recommendation. They may not be benefit design issues exactly, but they're certainly relevant to the topic. What I understood Cheryl to be saying was around the way that OHP supports mental health benefits and pays for mental health benefits is superior to how a commercial plan would do it. And
I don't think so, because any state health, federal and state subsidized health coverage plan falls short than the commercial market healthcare coverage plans, depending on which one it is, which HMO or managed care organization it is. So the nature of OHP is to pay lower rates for services than the healthcare market, the private healthcare market.
It's accurate that rates are too low. That's definitely another problem, but our experience is that Medicaid pays for a wider benefit array and a larger group of provider types. A lot of the complaints that we get are from people who have commercial insurance or Medicare.
Yeah, because we have a lot of specialty areas that are not even accepting Medicaid or Medicare plans. They are strictly dealing with the employer-sponsored based healthcare insurance coverage plans because they get more money. So this is why I say, let's not just limit it to mental health services expansion of coverage to OHP, even if they cover a larger expansion of services. Where we fall short is that they are, like I said before, the pay rate is lower, and therefore not as, the care is less quality because of that, because it limits access when the providers do not accept federal, state healthcare plans like Medicare and Medicaid, and we're growing in that despite the ACA. So we don't want to leave any ethnicity or, populations behind. But I agree otherwise, Cheryl.
So then I think, again, single payer world, universal benefits. Ideally, everyone would be on this. This is the plan that the providers would have the only option to really serve primarily, depending on whether we get Medicare in there right away. So the second bullet sounded like there was some enthusiasm for many of the things listed in 770 around evidence-based thinking, looking and expanding sort of a wrap around these benefits. Are people comfortable with that? Continuing to realizing the deficiencies currently in evidence stuff in terms, and all the discussions we've had so far, but that there could be, in order to define any limitations to the benefit categories, they would be a process of looking at it, building on some of Oregon's historical activities and moving forward to make them even better and more as patient-centered as possible.
Yeah, I think that would also address the requirements of SB 770 that says whatever the design model is, it must include existing plans services. So
right, as I think it was Sam said, as one of you said that that if you're on PEB now, you would go into this, you wouldn't lose benefits per se. If you're on OHP, you wouldn't lose benefits if you were on, etc. All right. Sarah, do you think we have enough to refine and define that?
I think so. And, as we go through this, just know that there will be something landing in all of your inboxes, where we try to capture all of this. And, I'm sure, definitely welcome you, strongly encourage you to, when you see that, review it and let us know what we missed or what we need to refine a little bit more. But yes, I think so for now, Janine.
Okay. So we can move on into the topic, which was put back on to the group for, to think about how to engage higher income folks through potentially some options, and premiums was raised during the task force discussion. Your proposal so far said, along with no other cost sharing, except in a couple instances, you said no premiums. OHP, we have a long sordid history around premiums that I won't go into, but right now we don't have premiums, but that's seemingly appropriate because the income level that OHP goes up to is fairly low, and not easily affordable, as we know from our past experiences with premiums. So I looked to see what kind of average premium costs nationally. Some say the family premiums are around $1,000 or more. Oregon, if you are an individual and you go on the marketplace and you are going, whether you apply for eligible for subsidies or not, your premium would start at $425 to $466 a month. After the subsidies, that gets lowered if you are in a lower income bracket to approximately $138 a month, with people at the lower end having a much better rate than those on the higher end. So we put through a proposal just to, knowing that in the past when we had talked about some other copays, we had kind of put it into buckets of those who make nothing up to 300%. And I wanted to remind people what that income level was. So for a family of 4, based on 2021 federal poverty levels, and those aren't perfect either. That's a family of 4 making up to $6,625 a month. We would propose potentially no premium. The next bucket would be those between 301 and 600. Those are monthly incomes from about 6,626 up to a little over 13,000. For a family of 4. And proposal here is to tier that potentially by income level. And then for those at a higher income level, over 600% of federal poverty level. So for a family of 4, that's a family that would be making $13,000 or $249 a month. We put out for something for discussion, $1,000 monthly premium. That's about half of what the pay is if you paid full fare as a public employee. The average PEB premium is running about $2,000 for a family. So that's about half of what a PEB premium is. Now, granted, under the state, the way it pays, employees not paying all of that. So how much, if anything, should be paid monthly by an individual and family? And what do you think of this proposal? Chuck has his hand up. Did anyone else? Yeah.
I have a question. What are the IRMA limits where seniors now have to pay more because of higher income 1 or 2 years earlier?
We sent those out, and I did not make a slide of them because
I'd like to know how they compare to these figures.
Yeah, hold on just a minute.
I'm trying to pull them up, Janine.
Okay. I don't think they're translated per month. I think they're per year.
Right. I just did the math on it, so everybody can take those numbers and multiply by 12, which I think is easier.
Yeah, and the reason I put them by month is when we were doing Healthy Kids a long time ago, it was important for families to think about what they'd have to pay out every month. So I wanted people to see, if you're being asked to pay $1,000 a month, how much of your total family income is that? So.
Right. No, both numbers are useful for
these kind of discussions. Yeah. So if you're an individual, it's 88,000 up to 111. I don't think these fall into those income levels.
No, I mean, we did family of 4 for the.
Yeah.
But. I mean, 600% for a family of 4 would be somewhere in, well, I don't know, it's hard to say actually.
So 88,000 is about 7,000 a month. And 111, so it's about 7,000 to 9,000 for that first bucket where you would be paying the 207.
So these figures are specific to the federal state health.
This is specific to Medicare. So when you first retire, if you're making above 88,000, and it's adjusted each going forward. So when you first retire, you might end up paying more because it's based, as you can see here, these are what you made in 2019 determined what you will pay in 2021.
Okay, that's not the point I want to make. What I want to, the comparison that I'd like for you to speak to is, will these same rates be applied to the private healthcare market benefit service plans, their package plans?
This is what's applied to Medicare. And
No.
what the proposal was, that you're in a single payer world where everybody is, whether you're a PEB employee, a Medicaid person, or you're in a private commercial plan, you would all have the same tiered premium. So again, we're thinking about the entire Oregonian population. And those at the lowest of income would have no premium. Those in kind of a little more the middle of the road would have it tiered, where lower income would pay. And I didn't actually, not knowing what you're going to pick for above 600, you could certainly then adjust what that would be for the 300% of federal poverty level, or 400, etc. And so this is all individuals in the state that qualify, that are living however it's decided that they're part of the single payer. This would be the premium. You wouldn't pay any other premium unless you chose to pay for some sort of private other insurance on your own.
Okay.
So I work for a company that has a health insurance, and they pay part of my premium right now. And so I would then switch over and be part of this single payer, and my premium would change based on my income.
Okay.
So Janine, I think part of this conversation too, I just want to loop us back to when the EBA tag had a cost sharing discussion a while ago. I think one of the things that's helpful to think about is, what are the goals? If there's cost sharing, if there are premiums, what are the goals that folks are trying to accomplish? And so one thing I heard come out at the task force meeting was an explicit goal of having premiums is to ensure that the plan is more affordable for low income folks, which is why you're having high income folks pay more. So that's a revenue objective. I think potentially there's maybe a political objective, a sense that, you know, that can a plan be passed if there's a perception that there's no premiums? And then I think there's also a sort of, well, I guess from where I sit, maybe those are kind of the two big ones. And then I also just want to highlight what Dr. Metz said earlier, which was to the revenue raising point. If you're looking to that you can raise revenue here, and you can raise revenue in what Finance and Revenue is doing with their plan, which is, you know, imposing higher costs on folks who make more money. So I think as you guys are giving feedback on the premium question, I think it's important to keep in mind like what the goal is of potentially making recommendations along this line. So sorry, Glenda, I didn't mean to cut you off.
That's okay, because you know, I just want to make sure that when we're contemplating these models, that we keep at the forefront of our minds how it's going to impact the marginalized population. We want it to be equitable and equal for those that are at the higher income level, as well as the lower income level, without changing the kinds of services between these two income populations. Just want to make sure everybody gets equal access to the same services, even though it's at a different income level.
If I may inject, I'm really starting to get chest pain about this premium discussion. If our plan includes premiums, we need to pay for an extra bureaucracy to determine what premiums each patient has to pay, and revise that every time a patient gets richer or poorer. Then we have to pay for another level of bureaucracy of insurance police to make sure that no patient ever gets care unless they can document that they have paid their premium. if at Nipper, thank you for repeating this, if the goal of premiums is to increase revenue, what is the advantage of creating these two new levels of bureaucracy to get money from rich people instead of using taxes to get money from rich people? I say that rhetorically because I cannot come up with an answer to that question. I think premiums will defeat the entire purpose of our single payer task force, which is to get people care as soon as they need it without an intervening insurance police.
John, and then I think then Chuck after that.
Yeah, well, I would strongly agree with Sam. Boy, I would not want to take on collecting premiums from 600,000 rich folks who are likely going to be doing everything they can to avoid having to pay for them. And I think going after lower and even middle income people with premiums makes it even worse. And oh my, I think we need to return to the Finance Committee and the main proposal, you know, let's get financing from wealthy people via a less expensive and more controllable resource. I also want to express concern that I think when you're getting up to $1,000 a month premium, you're going to have private insurers who we cannot, I think, prohibit from offering a high deductible basic benefit plan that will come in under 1,000 and they won't participate.
Potential unintended consequences.
Yes, and you're going to get selection. You know, the only problem I have is please, everybody's got to realize that Medicare folks in Oregon, I think, are already paying, I think, a couple $2 billion, if not more than that, in premiums for Part B and for supplementals. And, you know, and it's easy because they go through Social Security collects it. You know what I mean? I suppose this could be made more palatable, Sam, if the Oregon revenue folks said they would collect $1,000, you know, a month via tax forms or something. I don't know, but this just looks really difficult, you guys.
And Chuck, you previously had suggested premiums, so
I am not in favor of the chart that you had put up earlier. I agree with a lot with what John said, although I mean I do think you can do targeted premiums can collect money from wealthy people more efficiently than the broader taxes that we're talking about, and which get easily undermined by the lobbyists for those interests lobbying out exceptions. You know, if you have a sales tax and there's certain exceptions that affect the wealthy, they get lobbied out of the tax. And so, you know, I think you can do this through the tax code. It can be based on, you know, they basically do the eligibility. They look at what someone's adjusted gross income was. That's the eligibility versus, you know, the multi-page eligibility forms you have at the Department of Human Services and Health Authority to get public benefits, which are just ridiculous. It should be as easy as getting a.
If you can do it through revenue, and you know, not have to send out bills and try and collect them.
Right, you can. You know, I remember when we were talking welfare reform, the head of the revenue department at the time turned to the head of the welfare agency and said, "I can hand out this money every month a lot cheaper than you from my much smaller agency than the Department of Human Services. You know, they can do it if you have limited criteria. If you're not looking at wealth, you're just looking at adjusted gross income. It's there, and you can have a fee, or you know, it can be also I mean, one way of doing it is, let's say everybody was getting a credit for healthcare, but the people who didn't, whose income was above a certain amount, wouldn't get that credit on their tax return. It would be an annual fee based on your last year. It doesn't have to be a monthly payment or anything like that. So I think having something at the upper end, like we have with Medicare, should be considered in the mix for how to get it, because I think it's a good way of targeting those folks. Should it be at the same level? Would it start at the same income level as Medicare? Maybe not. But you know, those folks are paying it now, and you're not hearing a lot of complaints day in and day out.
So what I'm hearing is some folks don't want premiums at all. Some maybe with a different way of collecting it through the tax structure. Ed, you haven't said anything, so I'm going to go to you first, and then I think Sam has his hand back up.
Yeah, thanks, Janine. First of all, I appreciate all the comments. I always learn something from the people in this task force. And you know, my temptation is to pile on with those who are really against premiums. That's my instinct, because of the inefficiencies in the bureaucracy and the inability to do what we believe it's going to do. I'm intrigued by what I just heard Chuck say. That notwithstanding, I side with the group that is not for premiums. And I want to go back to something that John said, which is an unintended consequence of selection, which I believe will happen. And I encourage us to put this in front of the CAC, that specific question, and that is, you know, if you had, we have members of the CAC who represent a number of different kinds of insurances, but if given a premium, you know, at your current level, deductibles notwithstanding, what would your choice be if that premium drifted to a certain level? Would you leave the 770 plan, or so I think that deserves the greater community-based advisory conversation. And then secondly, I'm increasingly uneasy talking about something that we don't really have the information put in front of us fully. You know, we're talking about, you know, increasing revenue, and I haven't been part of the revenue conversation. So I don't really have a good feel for what this is intended to do. And so I would rather that we have to talk ourselves into something like this as opposed to talk ourselves out of something like this. If that makes sense. Thank you.
So, okay, Sam, you're next. And then we can see if and I haven't heard from some of the others, so.
In a way, I am in favor of what Chuck is proposing, which is a premium that is collected by the Department of Revenue. I would add that it has to be compulsory. Now, of course, compulsory premiums are taxes. What my nightmare is, somebody goes for care and a paid insurance agent by our single payer agency says, you can't get care because you haven't paid your premium. And the patient says, but I don't need to pay any premiums because I don't make enough money. And the insurance agent says, no, you're supposed to pay and you haven't. And then the patient says, but I don't have any money. In short, we produce exactly what's going on in the private health insurance industry now. If we can collect this premium compulsory, independent of point of care, then I'll support it. Otherwise, I'm with Ed. Give us the reasons why we should have premiums. But if we don't have good reasons, we should absolutely not do it.
Okay. Other thoughts from others who haven't talked? Michael, Glendora. Michael has his hand up first, and then we'll go to Glendora. Michael?
Yeah, good afternoon, everybody. I've been kind of quiet most of the afternoon. So I think if we're going to go down this path, by creating the premium setup, you are in essence saying that the current status quo is acceptable. I think if we're going to go for a universal health care, it needs to be universal to a system that works for all. And by putting in those premiums and how you're going to collect them and proof them is counterindicative of the purpose. So I would go along with John and Dr. Jenkins and no premium.
Glendora, I think you had your hand up, and then I don't know if Xenia and Cheryl have thoughts.
Yeah, I just want to reiterate that my earlier question, ensuring that the premiums were based on an equitable approach was not to say that I was in favor of any premiums. So I still believe wholeheartedly, and the members of CAC believe there should not be any deductibles, any premiums, any co-pays, any monthly co-insurance payments, no cost sharing, and everybody should be required or granted the same benefits under a universal health plan. That's all I want to say. Thanks.
And Cheryl, have your hands up?
I think for me, I'm on the Finance and Revenue Committee, and it seems like we need to get to $20 billion. So if we can get there with just the taxes, then I would say I'd be in favor of no cost sharing. To me, it's just a matter of getting to where we need to be.
Mm-hmm. And that, I think, only other, Xenia, did you have a input? I think you would, your previous was to not have any cost sharing, so. But
yeah, no, I agree with actually the conversation that's happening right now. I think that this should be if we have to come up with another pot of money to fill a gap that we weren't able to get to on the Finance and Revenue Committee, then I'd like to have this conversation. I think Michael's point is very salient, and the fact that we're having conversations right now about how people can already pay for or subsidize the care that we're going to offer them through a universal healthcare single payer vehicle feels like a hard swallow, so yeah, I'm appreciating this. And
okay. Well, I know we only have a little bit more time. I wanted to touch on one other cost sharing, which I kind of can guess what you're going to say, but there was, I'll skip this slide. Oh, okay. No, I guess, so you did have some cost sharing in your other one to encourage people to get care in the right place at the right time. So you had a small emergency room copay, $25 and $50 depending on your income. You also had some dollar limits on a few of the benefits. Any thoughts on either of those based on today's discussion? Do you want to leave those there? Do you want any changes made to those? So the one point is that you would not have any, we talked earlier about limits, no co-pays, no co-insurance, and then there was some further discussion about limits. So this sometimes comes up in terms of, crowns and glasses and all that kind of stuff. I don't know if you want to go there today, but we wanted to confirm that you still, I think we had $8,000 limit on hearing aids, for instance. If you still wanted to leave that in there, that I think Michael noted at that meeting that was fairly high compared to the limits on hearing aids. So I again, based on today's discussion, we wanted to just clarify whether you wanted to leave those two notable areas of some cost sharing.
I'm thinking that we don't need $12,000 hearing aid device if it is not going to enable us. I mean, if it to work for us to hear. So who's going to be the determiner of how what the limit is and what will they base that on? So whatever justification they come up with, I would like to see it be equal for everyone.
Sam, I think, I don't know if we should put you're both at the top of my screen, so I'll have Sam go first, then John.
Thank you. Sorry to go ahead of you, John. First, I am unaware of any data that demonstrate that co-pays in emergency rooms alter the behavior of people seeking emergency care. So unless we can come up with data that says people will use less emergency care if they know there's a copay, and that's good for people that they don't use emergency care, we should not have that. I am in agreement with the general concept. Janine, I think we should not go into it here, as you suggested, that there are certain services in which we need to have limits beyond which there are copays, such as dental, hearing, vision, and maybe a few other services. But we should not make those dollar determinants now.
John?
Yeah, well, as you know, a lot of my focus and concerns have been around Medicare. And I just want, especially when it comes to these three benefits, vision, dental, and hearing aids, to urge caution. Realize we just had a conversation. I think we're going to need to raise $3 to $4 billion to pay for the premiums and cost sharing in the current Medicare benefit. We're going to need to come up with substantial funds to do what I think would be the first priority, which is to improve the mental health benefit in Medicare. And I can't put a cost estimate on that. But I think I can make a case that covering vision, dental, and hearing aids in Medicare would cost another $3 billion if there was no cost sharing. All of the coverage that's currently out there for vision, dental, and hearing aids does involve significant cost sharing. In fact, 50% probably in all three cases. I want to remind everybody that this isn't a low income issue. All the low income folks in Medicare are also in Medicaid, or they should be. So their Part B premiums, their cost sharing, I believe is all paid. So, and I think that's about 25% of the Medicare population, but I'm not sure. So this is a middle income and upper income problem when it comes to Medicare. You know, it's a very significant issue. And I'd urge, when it comes to Medicare, we focus on the premiums and cost sharing and a better mental health benefit, and then get to these three.
So other thoughts?
Janine, I just wanted to jump in really quick and say that Dr. Metz, to your question, the only evidence that I could find around evidence for copays was for emergency room services for middle and upper income folks. And I'm happy to share that article out to the group if you want to take a look at it.
I would, please share.
Okay.
And so I think I'm hearing, but haven't heard from very many yet, to wade cautiously in terms of point of care copays. Currently, you have a copay suggested for emergency room. I haven't heard completely whether you want it to stay or go. Except from Sam.
Will you repeat that, Jean, please?
So the question on the table is, you have you previously in version 1 of your proposal, you had a copay that was tiered for emergency room. I think it's on the first, no, maybe not. Of $25 for those below 600% of federal poverty level. For those between 300 and 600. And you had a $50 copay for emergency room use for above 600% of federal poverty level, which was that $13,000 a month for a family of 4.
I'm against all copays.
Yes.
Okay.
Agree.
All right, so we now have others. So you had that before, so you're suggesting that we take that out, that you want to remove that point of care. Anybody opposed to that?
Yeah, can I jump in and say, first of all, I know that I've read the American College of Emergency Physicians, ACEP's recent conversation, and by recent I mean 2019. Since 2019, the American College has been focusing on the pandemic, but prior to that, there were several statements in favor of single-payer universal health care, not talking about copays, not talking about how, with a concept that if you expand care, increase access, increase relationships with primary care physicians and people within your network, then you're going to reduce visits way more than the disincentive of having to pay. Add in the complexity of administering, a copay of some sort. I am in favor, and I think I have the support of emergency physicians in general, but I'll speak for me. I'm in favor of no copays for emergency department visits.
So it's sounding like we're going to eliminate that based on what I've been hearing. And then the question about specific limits that might be some cost sharing related to, especially around vision, dental, and hearing aids, needs to be further examined, but not necessarily wedded to your original proposal of 8,000 for hearing aids, etc. Yes, Sam. Okay. All right, so that leaves us with one last area that we want to cover today, which is pharmacy, and talk about one of the more complex areas of pharmacy benefit. You had in your current proposal cover with no copays on brand names based on income, and no copays for anyone at any income for generic drugs. Just for comparison, the benchmark plan's covered with some restrictions, various copays, depends on the insurance company on the commercial market. OHP has covered using that preferred drug list that's developed in a public manner with the Pharmaceutical and Therapeutics Committee, and based on that input. And then PEB, again, they have vendor health plans. They're covered differently depending on whether you're on Providence, MODA, or one of the other options in PEB. So there is a lot of focus going on in the legislature right now on high cost of drugs and approaches, and as we have had for many years. I know, like in the MODA plans, they often use the Oregon Prescription Drug Program and other ways of bulk purchasing, etc. So what we were going to propose is that the benefits would include pharmacy, which is a good thing, as we know from our past experiences in Oregon when we briefly shut it down. That we would use a statewide drug list or formulary, as it's often called, that reimburses based on some sort of parameters, such as a transparent, evidence-based development of that list, But also it works alongside any other ways to control the cost of drugs, which are really challenging due to the complexity of pricing of drugs. So thoughts about this proposal? So it's basically somewhat similar to what we've had this discussion earlier about we want to go for maximum benefits, but we want a little bit of a wrap around it. And the same here would be that there would be this common list of formulary that everyone would be subject to and would be constantly evolving and changing based on the latest, greatest evidence and any efforts that the single payer and or the rest of the state government and others can help to bring the cost of drugs down for everybody.
Agreed.
Ed, were you saying yes as well? You were on mute.
Yeah, I'll go so far as to say what Sam said.
Agree. Okay.
Can Ed, Sam, can either of you help me understand why you're taking that position? Help me make my mind, review, decide whether or not I want to join you or not.
If I may, Glendora, the concept is the state of Oregon buys in bulk all those drugs that it decides to cover. This will take care of the high cost of medication because we'll be buying for 4 million people, and there will be some competition to sell us basic drugs like insulin, beta blockers, etc. We'll save money that way. Just so everyone knows, each year the FDA approves thousands of drugs. 80 to 90% of them do not treat a new condition. They are not safer than current drugs. They are not more effective than current drugs. In short, we don't need them. They do, however, allow patents, which is why drug companies sponsor the FDA approval. All right, that was probably uncalled for, but I'm not sure, Glendora, that I answered your question.
Yeah, because I'm thinking about, I don't like to be for healthcare consumers to be burdened with trying to make a decision on something for which they have no basic medical training or understanding about. So I don't want to see them agreeing to particular medications based on affordability. I would much rather see that they make this decision based on their provider's recommendation. But you're talking about the overall cost of pharmaceuticals and how we deal with the pharmaceutical companies in bulk purchase. Is that what I hear you saying, Sam?
So, hey, before Dr. Metz, before you answer, I think we're getting a little, this issue is so complicated, and Janine, please correct me if I'm wrong here, but I don't think we're talking about purchasing.
No, the question on the table was, yes, drugs will be covered, but we're proposing that that's through in terms of which drugs are used by the single payer. It would be based on a statewide drug list or formulary that takes into account the effectiveness in certain different populations may be different. All that sort of thought process would go in there. There may be other things going on and how that is purchased, and whether we purchase it with Washington and California and all together and do all sorts of things. But basically the benefit would be, yes, you can get your drugs covered, but they need to be on this formulary that's regularly updated with the latest, best, greatest information continually to work towards the best information available to make those decisions of what's on the list. And I think I saw Ed had wanted to say something a bit ago.
Yeah, I did. Sarah, did you want to add something quickly?
I just wanted to remind folks that in the original proposal, we did suggest pulling out part of the pharmacy benefit, the purchasing portion of it, because there is so much activity happening around the state and it's such a complex issue. And I don't want to force people into like a 3-minute discussion of something that's really complex. So I just wanted to put that out there, but go ahead. Dr.
Thank you. And I'm going to apologize. I have to go immediately after I say this because I'm supposed to be starting another meeting here. So I see this as a very focused statement, what is being proposed on this slide. It makes sense. It helps us align with other activities in the state. It is not prescribing, excuse the word, relationships between patients and their providers. I don't see it as dictating really anything that would directly impact things downstream. I see it as an alignment issue that just makes good sense. That's why I said I agree with Sam and I agree with this. And I apologize that I do have to go.
Okay, so I agree with Sam and Dr. Ed.
And I think there's some more comments. Are folks okay? It is 4 o'clock if we stay on just for a little bit longer to get the last discussions in for those who can. I don't know if John, are you before Xenia?
I think so. I just want to say this area is the area that is furthest away from the ideal. And that's, you know, Glenn, these are companies that are all about profits. These are companies that are all about money. So you have one side here marketing to patients, and their goal is to make huge amounts of money. And these companies have harmed patients right and left. They're great marketing companies. And believe me, there's many physicians who would love it if we could get to the kind of relationship you just described, but they would point out that it's the drug companies and their direct-to-patient marketing, direct-to-consumer marketing, advertising, bribes, rebates that make life so difficult for them. So I agree with the proposal. It's a start, but in this case, you know, the single payer could do some very creative things to make sure that patients really do know what the truth is about these drugs.
Xenia?
I just had a quick question about the pharmacy benefit. Does that include compounded medications, and or what would we do about things like supplements and other medications that may not fall under the pharmacy benefit? Is that a conversation for us to have later under some other health-related services, SDOH support, or would we need to expand the definition of pharmacy benefit here to include some of those medications?
I think that further refinement of what goes on that list, whether that list would include, say, over-the-counter meds, or is the single payer going to pay for those? Are they going to pay for supplements? That sort of thing. Those would all need to be decisions to be made down the line when you come up with that list. But it does also dovetail into those other areas as well.
Okay, yeah, because I saw on the previous slide, like, you know, in basically current proposal covered no copay, and then some of the, well, I guess we haven't even gotten to a place with enumerated, so I'll leave my question about like compounded medications, et cetera, on the back burner for later. Thank you.
Compounded ones are usually included. It's the supplements, you know, whether you should take this or that usually are not traditionally on a formulary per se.
And
some
like
of the
IV medicine.
CCOs,
Oh, I'm sorry, Janine.
Oh, and some of the CCOs pay for Tylenol and some don't.
that I appreciate that. The other thing I would add are things like IV medicine, so IV, nutrients, et cetera. Just in case I forget later, Sarah, it'd be great if we could just put that down. Thank you.
Right. Okay. So I think we made it through the bulk of this. We did have put in at the end the reference slides. So Sarah and I will be trying to capture all this very robust discussion that you've all had today, and send out a kind of version 2 proposal for you all to look at with feedback, and to be then eventually shared with the task force. Right, Sarah?
That is correct. And thanks, Janine, for all of that information. And, thanks to all of you for, I think this was a really robust discussion. And I really appreciate everybody giving their feedback. And yeah, we will get something out to you, and really would love your input. And I realize I don't think we have any public folks on the line today. We do not. So.
And we did have the one question that I think, was it Ed asked about the premiums to go to the CAC?
Oh, the CAC. Yep. So yes, thank you so much, everyone. And we will get something out to you as soon as we can for your feedback.
Awesome. Thanks,
Okay,
everyone.
Sarah, I have one
hours.
request. The question that he wanted to go to CAC, can you get it to me before April 19th? Because that's our next meeting. And
Absolutely.
I would like, yeah.
Yeah,
good.
for sure.
Thanks.
Thank you. All right. Bye, everybody.